Hi, everyone. Good evening. This is Catherine Mickelson at the North American Thrombosis Forum. Thanks so much for joining us tonight. We are delighted to have with us this evening Dr. Steve Deitelzweig from Ochsner down in the Big Easy, New Orleans. He is a hospitalist there, and he is going to speak to us tonight about atrial fibrillation, which is a very prevalent disease. And there's a lot of new information always coming out on that front. So thank you, Dr. Deitelszweig, for joining us.
Oh, you're most welcome, Kat, and really appreciate you even pronouncing my name correctly. Most of the time I Dr. D, so, which is true for your listening audience. There's my background, you see my roles, Professor of Medicine, University of Queens Clinical School. And really what I to do tonight and take you through the expedient manner, different aspects you'll see listed on the agenda. We'll start by discussing ways to improve anticoagulation management as far as opportunities go, but of course that needs to be evidence-based right from the get-go. And then I'll share a few very briefly some of the clinical trials that are realized so we could select an oral anticoagulant. That's what is oral anticoagulant individual patients. And then in this day and age, we have to think of there's the clotting, but then there's also bleeding. And if we do confront bleeding, how best should we manage through that? And then very important is transition care. So to start, as it relates to opportunities for improved anticoagulation management, just a general for the epidemiology of atrial fibrillation and recognizing, as you see the graphic to your right, that the projected number of adults with AFib are going to go up exponentially from where we've looked back, we're anticipating in the future. This has great relevance when we realize that not just atrial fibrillation patients are 5 times more likely to have a stroke, but 75% of those atrial fibrillation strokes can be prevented. Okay.
Well, Dr. Deitelszweig, I hate to interrupt, but you're fading in and out a lot.
No. All right. Thank you for doing that, Catherine. I will get closer to the computer and let me know if that's still the case.
Okay, this sounds much better. Thank you.
Okay. So in a study that I published, and this is in the Ochsner Journal, when we looked at atrial fibrillation patients and those managed by colleagues, a study of 55,000 of them demonstrated that over half of them were admitted to the hospital if you follow them over the subsequent 2 years for a variety of reasons. And when they do get admitted to the hospital, most of the direct and indirect costs of our hospitalization type costs. Catherine, am I able to be heard now better?
Yeah, Catherine? You sound great. It's perfect.
Okay, all right, then we'll stay with that approach. Perfect. And then here, when you look at the different types of strokes and systemic embolic event rates, you'll see demonstrated that you have notable reduction, significant reduction, in fact, when you go from no treatment to 18% reduction to antiplatelets, and then from there, 58% reduction if you use warfarin. And there you see the different trials on the x-axis, and we'll touch upon each of those in a few minutes, but it's the Bigatran, rivaroxaban, apixaban, and edoxaban. And those are the generic terms for the agents that you probably come most familiar with, which we'll go over as well. So really what I like to set the stage for all of your clinicians who care for you as patients is that right now, as a recent analysis demonstrated, over half the patients with atrial fibrillation are not on evidence-based anticoagulation. So what a gap that we need to close, hence the call to action. And the way we want to close the gap certainly needs to look at the evidence. And what we like to ask and make sure that's conducted is a risk assessment to see if you are a candidate for an oral anticoagulant. Again, OAC being the acronym. And if the answer is yes, then you need to make some adjustments, and it has the right inputs of being, well, what are the other medical problems that the person may or may not have? Were they represented in the clinical trials that I'll take you through? How about all the metabolism and pharmacodynamics, how the drugs are processed? How about the renal function? How about liver function? What's the usual dosing? Is it once a day or twice a day that is being sought out here? How about drug-drug interactions? And then do we have a manner in which we can look at continuity of care, which is so critical for these agents or transitions? So one of the areas that I see happening on a fairly regular basis is to recognize that if you're on antithrombotic therapy, you might be at risk for fall, not because of the atrial fibrillation, but because of this is a condition that have increasing incidence with increasing age, so arthritis or other conditions. And if you do fall, and if you happen to hit your head, you're going to be at risk for ICH, which is intracranial hemorrhage, or it could be traumatic, things of the like. And the elderly persons who have a mean fall of 1.81 per year, what this analysis, and the reason why I'm sharing this with you, is a lot of people might have fears about falling and what might result. But in this particular paper, it demonstrated that if a person's taking warfarin, you would have to fall 295 times in 1 year for warfarin to not be the optimal therapy. So that's a lot of falling, right? So this is just a background for people who have a fear of falling, and yet really that they demonstrate, the evidence is demonstrate benefit for being on anticoagulants. For those of you that love apps, the American College of Cardiology happens to have one that's really excellent. And I'm on the Accreditation Management Board Directors for the American College of Cardiology, and I've been exposed and used this app called AnticoagEvaluator. And in this app, it uses the tools that could assess your individual clotting or stroke risk, as well as bleeding risks, and looks at the options from the clinical trials. Here's one that I think is most helpful for people to appreciate. And the CHADS-2 score, and here's the CHADS-2 VAS score. These are the risk factors that go into assessing stroke risk, okay? And they've both been validated. The CHADS-2 score has been validated by the National Registry of Atrial Fibrillation, and it came from looking at 1,733 Medicare patients from the ages of 65 to 95. The CHADS-VAS score, which is more recent, came as a result, which is also validated, mind you, came from the real-world cohort of patients, over 1,000 of them, 1,084 to be specific, in the European Heart Study. So just look at these elements, and these are the elements that you should be thinking about to know your own risk score in the context of non-valvular atrial fibrillation. So heart failure, hypertension, age at least 75, diabetes, stroke, TIA, which is transient ischemic attack, thromboembolic history, vascular disease. You can have a younger age, but notice if you're 65 to 74, you get 1 point as opposed to 2 points if you're 75 years or older. And then female gets another point. And so you add up all these points. So look at these points that you added up, and then that gets translated into a percentage every year of what the risk for stroke is. So if I go back and let's say you have a CHADS-VAS score of 5, right there, your age over 75, you have heart failure, high blood pressure, and diabetes, 5. So that 5 when you translate here, is 6.7% of stroke risk per year. So that's one edge, one side of the ledger. That's your stroke risk. But this has to always be balanced against your bleeding risk. And there's different bleeding risk scores that have been made available to us. The most commonly used one, and these are all acronyms, but you should hear the term has bled. Has bled is a risk score that stands for H for uncontrolled hypertension, then A is abnormal renal or liver function, S is previous stroke, B is bleeding history or predisposition, L is labile, INR, so if you're on Coumadin, you know the INR is your value, E is elderly, and D is drugs, concomitant drugs, and or alcohol excess. And we look at this to see, we balance the clotting risk or stroke risk versus the bleeding risk. And as an example, I thought I would have you be exposed to JB, who's a 71-year-old white female with non-valvular atrial fibrillation. We call it NVAP. Past history is there as listed before you, and is on warfarin as well as many other drugs that we commonly see for general management of high blood pressure and things of the like. Ibuprofen is another medication that, mind you, we'll come back to, but could increase bleeding risk. And here you see that JB had fallen and is taken to the hospital after blacking out. That's what syncope is. And there you get some of the details about what the INR is. The normal range is between 2 and 3, but here you see it's usually 1.5 to 2 and has been over 3.5 on 2 occasions. See the vital signs? And with atrial fibrillation, you have an irregular heart rhythm, and that's what's detected here. But good normal creatinine, well, creatinine is 1.1, hemoglobin 14.4, which is normal, and there you see the INR. So you want to always ask yourself, what's the risk scores? What's your CHADS2? What's your CHADS-VASc? What's the HAS-BLED? And I just give it to you because I think that's helpful. But these are all what you would assess. You can assess yourself from that calculator app I gave you, or just you can even ask your physician or nurse practitioner or physician assistant, and I encourage you to do so. So at this portion, I want you to, it says that clinicians take an active role, absolutely, to identify appropriate patients, but patients could take an active role as well. And again, it's most patients who have a CHADS2 score of greater than 1, you'll derive the benefit from being anticoagulated, irrespective of your bleeding score. If you have low CHADS2 score and very high risk for bleeding, like a high HAS-BLED score, then you may not be a candidate, and we'll have to talk about that, which will occur in a shared decision-making manner. Next, I want to share with you some of the trials, not to walk you through this in extensive detail, but recognize that we have these 4 trials. One is called RELY, one that you looked at the Bigatran, one is ROCKET, looked at rivaroxaban, and that would be Xarelto, say. Aristotle looked at Pixaban, that would be Eliquis, and then Engage looked at Doxaban, which is an agent you're probably not too familiar with because we don't use it very much in the US. And there are nuances with some of these agents. I think the key portion for this audience, let me go to the next slide, would be to recognize if it's less than 1 off of that line in the middle, that favors some of the newer agents, which we'll call the DOACs, direct acting oral anticoagulants. If it's to the right, that would favor the traditional agent like warfarin. You see them, these newer agents by and large are looking quite favorable, but not all of them are off that 1. We'll come back to that. When it comes to bleeding, look at the same In the same manner, you'd like it to be off the line of 1 to the left. That'd be lower bleeding risk, major bleeding. And I'll define for you major bleeding in a few minutes, because I think that's a very important distinguishing aspect of all these medications to learn about. So the Bigatran and rivaroxaban, the first two there, you see, are not off the line of 1 or unity line, whereby the others are. The area where I spend also a lot of my research time and want you to be familiar with in general is randomized controlled trials. That's what I just shared with you. These are trials that really lead to the Food and Drug Administration making the approval of these medications so they get put into as options for your clinicians to decide what's best for you. But then we also have RWD, which is real world data. And this comes largely from the use by clinicians in routine clinical practice. And that gets collected, and we use that information to help look at, is the drug effective over time? How about the costs, quality of life, maybe even some other aspects. And these often could involve patients that would not be in a clinical trial or randomized controlled trial. Let me just take you to the next slide. So as I mentioned, to your left, it is the randomized controlled trials, and it's not an and or, it's both. You need both randomized controlled trials and real world data or real world evidence to inform us to be what's best for our patients. Now you'll see they each have their advantages and disadvantages. Randomized controlled trials are extremely rigorous and randomized, but the issues there is that people might not be suitable to go into one of those, or maybe they're highly selected patients. And a lot of times someone might be very obese or maybe had an advanced kidney or renal disease, and they won't be eligible for one of these trials, and they usually have a short duration. So those trials, or those disadvantages, are exactly where real world data could help a lot. So think of it as a yin-yang. They're complementary in assisting. And the real world data is not perfect either. They're not randomized, so they're going to be subject to some statistical limitations. We'll leave it at that. What I'm largely referring to is data that comes from 3 sources. It could be claims data, electronic or paper medical records that does still exist, believe it or not, and different types of registries. And they each have, again, their strengths and weaknesses or limitations. This is just one that I published, now it's about 1.5 years ago. We call this the Million Study because we looked at quite a few large databases. So these were from commercial lives for the most part in this data set, and then you make some adjustments and you see how people are doing over time and you try to capture that. That's an example of a real world data. And you want to know, is that consistent or was it not consistent with the randomized controlled trials? When it comes to individualizing oral anticoagulant therapy, just to appreciate that there's the DOACs or NOACs, and then there's Warfarin, and they're going to vary. And if there's questions that come up during the question and answer session, I could go through that, but I wanted you just to be aware of this page. In general, very importantly, from the pharmacology, you should know the half-life of these medications are about 12 hours-ish. As a result of that, they're mostly going to be BID, twice-a-day drugs, but they could be once a day as well. The real message is if you miss a day of this type of therapy with these medications, you're no longer anticoagulated for many of the patients. That's different than what we had seen traditionally with warfarin. If you miss a day or 2, maybe even 3 days of warfarin, it would take a while for all that product to leave the body. Not so with these medications. One day and you're now back at whatever your baseline risk is, as if you're not anticoagulated. So remember that. We adjust these medications for renal function, so I wanted this group to be familiar with that. And then some of them need to be taken with medications, with food, others not. So there are nuances here that I would like for you to have good dialogue with your clinicians and not just, assume that you can or cannot take it with meals. Very few drug-drug interactions. If I had warfarin here, you would see just so many. Here it's pretty limited, and most of the current electronic medical records will target, or the pharmacist will inform what you have to do, where their dose adjustments might be needed. And this, I just wanted to share with you this slide because it looks at you individually. So you'll see in yellow to your left specific patient characteristics. So if you have someone who has that high bleeding risk, remember that's the HAS-BLED score, that's an acronym, then you want to choose an agent that has the lowest bleeding incidence. Maybe someone had, let's go right to the bottom, the patient preference. And maybe you want once a day as opposed to twice a day. So there are all these differences that we're entertaining on a regular basis to try to select the best medication for you. So when choosing an oral anticoagulant, most important, make sure that all patients receive an appropriate one, but we need to recognize stroke risk, bleeding risk, your preferences. Okay? In the clinical trial, yes.
Oh, we just had a question come in that before we move on to the next section, I thought would be kind of good while we're on this topic. So the question is, if you were stricken with atrial fibrillation, what agent among all would you want your physician to prescribe?
Right, so that's not a surprising question because I mean, there's several options for folks. And it depends on who your risk. So if I go back, if it's me, I'll share with you that I don't have high risk of bleeding. So maybe that's not something I'm not as concerned about. Maybe I didn't have a prior stroke. So therefore, that in the middle won't be quite as important. Maybe I have renal impairment, maybe I don't. So there is not a single answer. You have to map out and enumerate all the characteristics, and then you would land in what's going to be the best for a person. So there's not a one-size-fits-all singular medication. You really do need to have the conversation, sit across from the bedside, and go through, all the right clinical inputs. I would be doing a disservice to just answer and give you one medication for all patients. But thank you, Catherine, for asking that, and please feel free to weigh in like that anytime you like.
Great, thank you.
Of course. So I was simply going to share that, remember, each of these OACs are at least as equivalent to standard warfarin based on the primary outcome of stroke systemic embolism. And I do want to get into some of the bleeding aspects, which I'm going to do in a few minutes, but very importantly, like critical, you need to, whatever is prescribed, you need to be adherent, because I'm here more so than other areas, because if you're not within a day, it's as if you're not even anticoagulated by and large. And remember, warfarin still may be a good choice, and that could have been an answer as well. So let me move ahead to discuss bleeding. This is really important. And the way I wanted to start this is with these quotes that came from a recent trial. The trial, I think, is relevant for what I want to convey. And that is that despite the safety of these direct oral anticoagulants, they have been concerned that, unlike vitamin K antagonists, they came to us without an antidote. Okay? So many patients were discouraged from taking these medications until the antidotes were available. Today, that's changed. So first off, we don't use antidote as terminology. We use reversal agents. But being that as it may, I don't want to hold pat on nomenclature. But what I want to say that now the reversal agents that exist directly affect very few people because these are safer medications than what we've traditionally had in warfarin. However, they indirectly help many, many patients because I believe now that we have many of the reversal agents at our disposal, recognizing they're not going to be needed too often, it gives confidence to the providers, to healthcare professionals, but you also as patients, you should know that that is now part of our armamentarium. So this has really been just an incredibly important time over the last year or so in this space, because bleeding was such a concern that people wouldn't go on anything that you couldn't reverse. That's changed. And what I wanted to let you know that there are wonderful guidelines to assist us. This is just one of them that came from the American College of Cardiology. There's others, and they've come from the Anticoagulation Forum. They've come from European Heart Rhythm Association. They've come from the European Society of Cardiology, and they're all there and they're all helpful. And basically, the way these things work is that they go through some definitions. I'll share them very briefly, and then they take you through different treatments and sub-treatments, subcategories of treatment, and then importantly, taking you to the last mile, like can you or should you resume anticoagulation based upon what type of bleeding, if you did have one, and what would be the right dose. So here's how we define it. It's just major or not major. Pretty easy. It's major if you bleed into a critical site, if you have hemodynamic instability, which means your blood pressure is too low, like the systolic blood pressure, the top number is less than 90, or it's dropped by 40 points. Or if you stand up and the top number drops by 20, or if the bottom number drops by 10. That's hemodynamic instability. And then another option is that if you require 2 units of transfusions. If you have that, one of those, that's a major bleed. If you don't, not major. Very basic. Really important here is the last bullet to share with you is that these pathways are, while they're helpful for all types of bleeding and all types of reasons why people are on an anticoagulant, the key thing is that in this day and age, it's all team-based care. So whether I'm a hospitalist or a cardiologist or ER emergency medicine doctor, we all need to work together and certainly involve the patients and the families with this shared decision making. That's the goal. You always want to get a history, but really important here is the time of onset, not just the location, but how severe the bleeding is, and is it continuing? And you want to know when you took the medication, because unlike many times in the past, here, based upon what within a certain number of hours that we learn, you could actually change your management. I'll come back to that. And then you want to know, obviously, if someone has kidney disease or liver disease, because a lot of the medications we use are being processed through those organ systems. This is just a table that lists the critical site bleeding. And obviously it could be things that you would expect, like intracranial bleeding, bleeding around the heart or your airway, but also in the joints, the extremities. That could also be critical site bleeding. And this was really a nice table that was published. This was December of 2017 that shows you type of bleeding. It teaches you what are the initial symptoms and signs to look for, and then what ultimately could occur with this type of bleeding. So a very helpful table that I bring to your attention. And this is from the European Society of Cardiology. That's what ESC stands for. And it walks you through this very carefully, whether you have a minor bleeding episode, a moderate bleeding, or if it's life-threatening. and whether you're on, what type of medication you're on, and what you should consider doing. So there's a lot now that we can do that we didn't even know to do before. And this is what I'm listing for you to think through. And here is the guidelines that actually, since they came out, they're actually almost antiquated, because that's changed some since they first came out. For example, for vitamin K, that's warfarin, vitamin K antagonist, it's correct that it's something called a 4-factor prothrombin complex concentrate. It's a really complicated words, right? For dabigatran, that the first line there is called, look at that one, I dare you sisomab. It's like, I dare you sisomab, right? That kind of thing. And then the last line, which is apixaban, doxaban, and rivaroxaban, the first line was the 4-factor, 4-FPCC, but now it's something called indexamib. That was made available by the Food and Drug Administration back in May of 2018, so about a year ago, a little over a year ago. And that's what's shown here. For this purpose, I won't take you through the mechanism of action or necessarily the dosing, but just recognize these are all intravenous type of medications that we give, and we don't give them very lightly because they're very expensive, and they could increase your risk of clotting. And that's important because most major, even major bleeds, forget just minor bleeds, but even major bleeds, the majority of them can be managed without any reversal agents. And I think that's an important message. So just because you're bleeding doesn't mean that you should get something for the bleeding. A lot of times just an observation approach and supportive care will be more than sufficient. And that's an important lesson for everybody to think about. But what if you do have a bleed? And what if it happens to be a major gastrointestinal bleed? And there are some things that you could think about, but by and large, if you don't have the issues listed here, like if you're not very elderly, if you didn't have an unidentified site of bleeding, you haven't had this recur, if you're not have a problem with alcohol abuse, if you're not on other anticoagulants, in that regard, you absolutely should resume anticoagulation even after gastrointestinal bleed, and you should resume it pretty quickly, usually, certainly within a week, if not within a few days. And the reason why we say that, let me see if it's here, is that the evidence from meta-analysis, one type of study showed that the mortality, your death, and your likelihood of recurrence, your death is lower if you resume it, and the recurrence is not any higher, recurrence of GI bleeding. So that's what both the American College of Cardiology and European Society of Cardiology has to say, that most cases of gastrointestinal bleeding, this committee favors reinitiation of the anticoagulants, okay? Even if you never found a source, very important. And then, again, there are absolute contraindications for why you would not go back on an oral anticoagulant is very rare. So that's hard, because when you just had a bleeding event, you're a little leery, you're scared, but this will be that's the right circumstance to resume anticoagulation, and there's guidelines that support that, and that's what I'm highlighting here. The other thing just to be mindful of, the reason why also I wanted you to know that it's important if you ever have bleeding to let people know quickly how many hours ago did you take your medication, because activated charcoal could be given just by oral ingestion and remove about half the medication, and there's some case reports of that. Dialysis can also be an option. For time purposes, I'm not going to take you through this last case. I will conclude by discussing transitions of care and what elements I feel should go into your education about these medications. So I have to your left some educational basics regarding anticoagulants, the risk-benefit analysis that you should undergo in assessing healthcare, right? We want to know why you're taking this medication, how the drug works and some components, what are common symptoms and signs for bleeding or clotting for that matter. Know the side effects. Remember to let folks know that you're using an anticoagulant. And then carry the ID card. I am always surprised that more people don't carry the card or a medical bracelet or a necklace. Adherence, lab monitoring, and diet and lifestyle. You need to take these medications as they're prescribed, because if you skip a dose, it's as if you're not anticoagulated within 24 hours. But also the different recommendations to do if you accidentally miss a dose. Sometimes it's just resume at the next scheduled time. Other times it may be a doubling up. So you need to ask about that, or you should be informed, but you should ask as well. Lab monitoring, by and large, unless you're on warfarin, you should not have the need for any lab monitoring. But you should, as it relates to anticoagulation, but you should monitor periodically the kidney function or renal function here stipulated, because many of the drugs are metabolized that way, and you may need a dose adjustment if your kidney function is not stable. And as far as diet and lifestyle, not too much there. We always advocate to avoid alcohol, influence of dietary vitamin K if you're on warfarin. And this has key takeaways, the steps for safer anticoagulant prescribing, they're enumerated here. And these are just simply check boxes that came from the Annals of Long-Term Care. And they're largely duplicative in this summation of what I shared up to this point. I'm going to conclude by asking you to download from the App Store the AnticoagEvaluator app, as offered free by the American College of Cardiology. So with that, I will keep this slide up and conclude and be open for any questions that anybody may have, and really appreciate the time to come and learn together in this area.
Well, thank you so much, Dr. Deitelzweig. That was a wonderful presentation, and you certainly covered a lot of ground. So we appreciate that. So we did get some questions come in, so we will dig right into those.
Sure.
So the first one that we received was, is there any information concerning a mitral valve repair causing AFib?
Right. So the risk factors for atrial fibrillation, whether it's valvular or non-valvular, can to overlap some. But even after having the procedure itself, be it with a mechanical or bioprosthetic valve, it could itself lead to peri-procedural atrial fibrillation. So the answer is yes.
Okay, very interesting. Can you prevent AFib?
AFib, great question. AFib prevention is hard because it really dictates the early, you may recall when I looked at the risk factors, it's heart failure, hypertension, age, diabetes, stroke, and TIA for risk factors from AFib causing being as risk for stroke and systemic embolism. So you would go back a step forward, go back a step and say if you had hypertension identified, to treat that aggressively early. Well-managed diabetes, well-managed heart failure, could that be preventative for development AFib? Unknown. That would be, but certainly one would advocate doing that anyhow. Mm-hmm. That's for the persistent or chronic atrial fibrillation. Remember also, what I didn't go over, and what you would not endorse anticoagulation for, are people who just had transient or sort of temporary atrial fibrillation. There are conditions that could set that up. So for example, here I am presenting from New Orleans. We have these events called Mardi Gras and Jazz Fest and French Quarter Fest, all these parties. And a lot of people tend to drink more than they should during those times. And there's something called the holiday heart. So if you have a lot of alcohol, sometimes you can develop holiday heart. And that could be atrial fibrillation, but temporary, theoretically, transient atrial fibrillation. So those are all situational based atrial fibrillation. You want anticoagulant, coagulate, but you could prevent that by, i.e., not drinking, things like that. So there are conditions that are reversible conditions. That I just gave you. One is holiday heart. Another could be hyperthyroidism, overactive thyroid gland, things like that. So good question. Probably got into more of an answer than you were expecting.
No, that was great. And just kind of a follow-up question to that is, if you're prone to, this temporary AFib, in situations like if you drink a lot, does that mean you're more prone to developing kind of chronic or long-term AFib later, or is there really no link?
Yeah, that is in of itself, for that temporary situation, does not have a link. However, if something like alcohol affects systemically, so it's not just the kidney that people think about, it can affect long-term brain, long-term kidney, long-term heart. And if for whatever reason you wind up having a cardiomyopathy or something like that, then that could also put you at risk for the pathway that develops atrial fibrillation.
Okay.
So it does get intermingled some.
Okay. So when going back to like the CHAD score, what is it about being a female that puts you at a greater risk for AFib?
Right. So that wasn't the CHAD's 2 score. Because the sex does not play into the CHAD's 2 score. To be specific, it's the CHAD's 2 VASC score. And in the CHAD's 2 VASC score, one of the categories is female, is that sex category. And remember, that came from a real world cohort of patients from the European heart study. And it was simply just an identifiable component, risk factor, so it was unknown what was specific about being female that put you at risk, but being female did put you at risk in the way the data sets are cut. Just like being male puts you at higher risk of recurrence for venous thromboembolic disease. Kind of the opposite. Yeah, so those are just something to just recognize, but it's important to recognize it because it is a risk factor, and being a risk factor, higher likelihood of development if you have it. So it's great to be a lady, but maybe not so much as it relates to atrial fibrillation.
Right. Right. So is it safe to exercise with AFib, and can it trigger atrial fibrillation?
Right. More than being safe, we is encouraged to lead a healthy lifestyle, and exercise is certainly a portion of that. Within, not to be excessively exercising, and excessively exercising is an individual analysis. So yes, exercise, and what a trained athlete considers excessive is going to be very different from someone who's a weekend warrior, from someone who hasn't done much outside of sedentary work for 10 years and now decides to do it.
Yeah. Okay, but it is encouraged.
So absolutely. yes, be encouraged.
Great. If I'm on an anticoagulant for DVT PE, am I protected against AFib?
Right. So those are both thrombotic risk conditions with different mechanisms of action. And really, if you have non-valvular atrial fibrillation and you have VTE, there are medications and some doses of the medications that would be that are approved by US FDA to help both conditions. But if you are on it for VTE, I would not assume it to be the right dose or the right duration that would apply to non-valvular atrial fibrillation. Sorry to give a non-committal answer there, but I really don't want anyone coming away say, okay, if my prescriber, my physician decide to use whatever it was, and because sometimes the dosing is very different for non-valvular atrial fibrillation. It could be higher, it could be the same, or it could be lower. So you really you have to think about which agent is chosen and when it's chosen, because often in venous thromboembolic disease, you start at a high intensity dose for a period of time, week to 3 weeks, then you decrease the dose, and then after maybe 6 to 12 months, you may decrease it again. That's different than for non-valvular atrial fibrillation, whereby you'll likely be on the same dose throughout the duration on a long-term basis. So time, it's a dynamic based on time. You might get lucky and it's the same one, the same drug at the same dose, but that would be surprising.
So it is important, though, to have a conversation with your healthcare provider. Even if you're on an anticoagulant, if you're subsequently diagnosed with AFib, you want to have a separate conversation about your treatment for that.
Certain. That's a good that's a good takeaway from there, and I would never be so presumptuous to say, yeah, if you're on something for one indication, that it would cross and be beneficial to another. That would be what you suggested there, or what you recommended there is absolutely correct.
Great. Is it true that strokes are more severe in patients with AFib?
Strokes are more severe. That is absolutely correct. And in fact, strokes due to atrial fibrillation certainly have more severe disability, but worse than that, more likely to cause death, higher mortality. And there has been that's in the published literature fairly recently, going back. And actually it's even worse if it happens in a hospital versus in the outpatient setting. But yes, if you as a summation statement, that is a good takeaway.
And is there any idea about why that is?
Epidemiologically, it was detected, but it seems like the vascular zone of the brain that gets compromised tends to be larger with embolic strokes.
Oh, interesting. Okay. So that's all the questions that we got from the audience. I do like to kind of
questions.
Okay.
Yeah.
Well, I do like to ask kind of one general question to every, all our presenters is, do you have any words of advice to patients either with AFib or on an anticoagulant or, DVT PE? I know you see all these types of patients. So any kind of, parting words and some advice for them?
Yes, this is a special audience that I'm presenting to be so interested in their healthcare, in their health, and to join webinars like this. What I would say is stay tuned because it's such a dynamic field. Look at that app to be familiar with that. Would be one, and then also there are forums like NATF that does a phenomenal job, but that you may have the ability to interact with patients like me, like yourself, and have some discussion with that. I think that's helpful. So stay close to the evidence. Look at NATF, look at ACC, look at the Anticoagulation Forum, and then associate with other forums of folks with like conditions. I think that's usually helpful. That would be my advice.
Well, I think that's very sound advice and a good note to end on. So thank you so much, Dr. Deitelzweig, for your time this evening and for your wonderful presentation. We really appreciate it. For those of you who might want to, I know we covered a lot of information tonight. If you ever want to rewatch anything or, even show your healthcare providers, we do put recordings of our online support groups on the NATF website under the Patients tab and then Support Groups. So feel free to go back and reference this presentation at any time. Our next support group is August 13th at 7 p.m. We are going to have Dr. Alex Schmeier at Brigham and Women's Hospital present an update on treatment options for VTE and related cardiovascular issues. So Dr. Deitelzweig, thank you so much once again. I hope that everybody has a wonderful week.
Thank you so much, Catherine, for organizing, and give special thanks to Dr. Goldhaber for the invitation. I enjoyed it a lot.
Wonderful. Well, we enjoyed having you. Thanks so much.
Okay, now. Bye-bye.
All right. Good night.
Good night.